Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
Because nostalgia can be an important psychological therapeutic intervention. Because thinking of your past memories, as you mentioned, good and bad, and what you've learned from them, can sometimes cause you to emerge from a depressive state and become more positive. And so there's an article that talks, that's the first time I've seen an article that actually put into perspective how nostalgia, looking back into the past and the positives and the negatives, and thinking about how you can even be better in the future, can be very uplifting and positive, just like music, because music does the same thing. You get those old records that remind you of how it used to be, and sometimes it's refreshing. So it's just an interesting thought about how looking into the past and reminiscing can make you become positive about the future. And it may well be therapeutic intervention that we could use much more often, that is.
Dr. Callender, I have a question about that. What is the opposite of that? When you are thinking about something in the past and it's a dark memory, and then you bring it forward, and does that cause depression?
That's nostalgia. It's just that depends on your outlook. You're right. You can use nostalgia as a positive or a negative influence. But if your mindset is to learn from whatever mistakes you made in the past, then you can make that negative a positive. Anyway, it's food for thought, something to think about. Okay, you can start. We got a number of articles today. Oh, that's funny because last week we talked about it. One of the oldest practicing physicians who's 102 who died actually. And this is another person who's 100 years old and still practicing. So it's interesting how that some people stop at 60, some people stop at 45, some people stop, and some people never stop. And now this is a gentleman who's still practicing. His 75th year practicing neurology. And it's interesting, amazing. And so it's just goes to show that some people are blessed so that even at 98, 99, and 100, they continue to have the brain power to continue to work and to be physicians at that. And so it's nice to see. We've had articles that talk about how do you deal with the aging physician. And one of the things that's important is that one size does not fit all. And so it's your cognitive abilities that remain that help you to be able to be practicing as long. And so if you're at 60 and your cognitive function is no good, it may well be that's time for you to retire. So whatever your cognitive abilities end, I think that's when you should talk about it. And this is an article that talks about how you measure cognitive decline, and there are ways of doing tests, and that's what should be dealt with, not your age, but your cognitive abilities, and are they impaired or not? And so age is not the criterion. Actually, the best criteria is your cognitive abilities to function at whatever age you are.
Dr. Callender, it's interesting that that other doctor was practicing neurology, which means that he knew a whole lot about brain function and use it on himself.
I doubt. Yeah, that's one way of looking at it. I look at it differently. I look at it that's just a gift, and it just happened that he practiced neurology, because there's many neurologists who are not 95 and practicing. So I don't attribute it to his practicing neurology, but who knows? There's an article we included because I wanted us to review some of these symptoms that demonstrate that you need to see somebody before you drop dead. And sometimes recognizing that you have a problem and recognizing the symptoms that occur as a consequence of some of these symptoms can be an important way to getting them treated and actually expand your longevity. And I think that as you go down, you see that some of the symptoms are common and some of them aren't common, because you have all kinds of things. You have shortness of breath, fatigue, sweating, nausea, lightheadedness, and as they stand alone, they may not mean something. But if you have these symptoms and you get them evaluated, whether you have before you have a heart attack, shortness of breath, sweating, cold sweat, fatigue can sometimes be the beginning of a heart attack. And so if you have any of these symptoms, it's important to go to the doctor. Now, the thing about the heart attack is in women, sometimes the pain it is not in the chest at all. It may in the jaw, maybe in the shoulder or the back. So when you have any pain on the left side or pressure or discomfort, and indigestion, for example, is heart attack until proven otherwise. So, and then shortness of breath is a classical symptom of heart failure. This sometimes is one of the ways you know that you've had a heart attack, because your heart's failing. But swelling of the ankles, swelling of the fingers, sometimes vomiting, fatigue, and sometimes pain, sometimes not. But heart failure, as you know, heart disease is the number one cause of death in the United States and probably the world. So if you have swelling of the ankles, you have any of these symptoms, it's important to be evaluated by your doctor. Valvular disease is a little different in that it presents in a similar fashion, but usually you don't know it until you go to the doctor. As you age, aortic stenosis, we mentioned this last week, I think, which is a narrowing of the largest blood vessel in the body, occurs, and this may cause decrease in circulation to the heart, which itself can result in heart attack. So that aortic stenosis and valvular disease is a common cause of heart failure, and so that can be treated by surgically and non-surgically. So it's important if you have chest pain or shortness of breath to get that evaluated. Stroke, of course, is one of the most important cardiovascular complications. Occurs when the vessels of the blood to the brain is blocked, and the acronym FAST is well known, but face drooping, arm weakness, speech difficulty, any of those needs to be dealt with immediately, because we now have ways to dissolve the clot and eliminate some of those long-term complications of a stroke. And so early diagnosis becomes very important. Then, of course, one of the the worst complications of all is the rhythm disorders called arrhythmias, because they are more often the cause of sudden death than anything other than heart attacks, because the heart just stops beating, and then that's it. And so if you find that you have a fluttering or palpitations, then you should have an EKG to find out if palpitation is just the sense that the heart is beating fast, and it may or may not be the case. An EKG would indicate whether you have an arrhythmia or not. And they are often treatable by different treatments. And then finally, peripheral artery disease is a disease that affects the blood vessels in the lower extremities, and of course, pain in the calf muscles while walking is called claudication. Is the number one way in which that reflects itself. That's the symptom that means that you have peripheral artery disease. You have calf pain when you walk, and then when you stop walking, it goes away. And so this is a sign that the circulation to your legs is not good, and that you may need to have something done to increase the circulation. This is more likely a problem with the arterial circulation, although venous disease occurs as often. Of course, that does not manifest itself by cramps and walking. It's manifested by just pain in the calf. So I just point those things out because nowadays we have many ways of treating all of these. And so because you have those things doesn't mean that you have to die from it, but you can go to the doctor and have the diagnosis made of it, and it can be treated. And so that's why we include all of this stuff.
Dr. Callender, I had a question about varicose veins. Is that a symptom of this disease that we're talking about?
No. Varicose veins is a different entity. And what happens is the backup of the circulation in the veins, and they swell up. And sometimes, very often, they're asymptomatic. But if you get swelling of the legs, sometimes that can occur. And then, of course, if you get clots in the varicose veins, then they can cause thrombophlebitis, and that could cause pulmonary embolism. But usually varicose veins are ugly, but often are not problematic.
What is phlebitis? I've heard about that, but I didn't know what.
Phlebitis is inflammation of the vein, and if you have varicose veins and no clotting or phlebitis, then it's not a problem. But if you have phlebitis, that means you get a clot in the vessel, and the vessel can break off, go to the heart, cause pulmonary embolism, can kill you. So that phlebitis is a disease that needs to be treated immediately. Varicose veins is ugly, but usually not, doesn't require immediate treatment. You can have treatment for that because they have many venous centers. All they do is treat the varicose veins.
And all of this is very timely for me. Dr. Callender mentioned I was having a pain in my hip on the left side. And one doctor said sciatic nerve. Someone else says, no, I'm seeing a neurologist. So I've gone through a series of tests, every Doppler that you can think of. They've been doing that, the carotid Doppler, the transcranial Doppler, and other tests. I'm having an EEG next week for the brain. I've done cognitive tests. And actually during the course of all the testing, the pain is slightly better where it was unbearable at one time. But I'm gonna see it through to see what the final diagnosis is.
Sounds like a lumbosacral disc, but it'd be interesting to see what, after all the tests.
Well, I had an MRI yesterday.
Good.
That one That was on the hip and the pelvic area. And then next week, the MRI is on that EEG thing on the brain.
Okay, well, we'll be praying that you get an answer to your question and get better. It's nice that you're getting better anyway.
Yeah, I think the poking did it. Once you've had that Doppler and they're testing the nerves and the muscles in the leg, I mean, you're jumping all over the place. So maybe it jumped the pain out. I don't know.
Not likely.
I'm wishful. I'm hopeful.
Yeah. This is an article on vitamin D that we talked about. And one of the things that we have to worry about, and not only is that taking too much vitamin D. Vitamin D is a hormone that helps our bodies absorb calcium to strengthen our bones. But overdoing it can cause other problems. And so it's a good idea to get a test to see if you're vitamin D deficient, because if you are, then you need to be treated. But if you aren't, then taking those high doses of vitamin D can be harmful. So a lot of African Americans have been found to be vitamin D deficient, and I thought that plays a role in heart disease, diabetes, and kidney disease as well. So I talk about foods that you take that are rich in vitamin D, and there are many the seafood, other things that are high in vitamin D. Of course, we put vitamin D in milk. Of course, that is good for those who are not lactose intolerant, and many of us are. So that's a concern. So that it's clear that vitamin D deficiency causes problems, and not only the bone, but it also causes other problems that relate to your ability to fight off infection, fight off diseases. And so having a normal vitamin D level is important, but taking too much vitamin D is not good either. So you have to, so it's my suggestion that before you take your vitamin D, you get a vitamin D level and see if you need it. And then this talks about the food that you can eat to avoid taking vitamin D, because vitamin D is already in the salmon and other things that you have listed here. And so anyway, this is an interesting topic that we discussed before, and we'll discuss again, because osteoporosis is one of the fears as you get older, that your bones get soft, and of course one of the most frequent killers of older people is falls and breaking bones, and that leads to inability, which leads to death. And so one of the things to do is to avoid vitamin D toxicity, which is something you can do just by not taking too much vitamin D, which is recommended. And when people start taking more than 3,000 to 5,000 units of vitamin, then that can cause problems. So if you're not taking vitamin D, then you're not likely to have this. But if you are taking more than 5,000 units of vitamin D a day, then this can also be a source of problem. Now, exactly what problems, that's debatable. There are many people who think some of the lymphomas occur as a consequence of detoxicity. But the most common cause is by taking too much vitamin D, which is unnecessary. And so, and that can be identified by having blood tests as well. And these are some of the symptoms that you see with vitamin D toxicity. And most of them are not directly, you wouldn't think of them. Confusion, depression, psychosis, and all those things very similar to what you have with hypercalcemia. But the best treatment is not taking too much vitamin D in the first place. And everything that you see here related to hypercalcemia is what vitamin D causes. And the hyperparathyroidism, that is a disease that is associated with renal disease, is associated with, go back up there, I wanted to show that. Go ahead. Stones, bones, stones, groans, and psychiatric moans. All of those are the manifestations of hypervitaminosis D. Sometimes hearing loss and cataract, calcium deposits in the cornea occur as well. But the most important thing is to stop taking any vitamin D supplements, and sun exposure can be a problem. Other treatments, steroids as well, and bisphosphonates can be used. I think one of the most important things is to avoid it, because that's the number one source. Now, this is interesting because, you know, we heard a lot about garlic, and especially with the vampires. And garlic was killed the vampires. But anyway, it appears that garlic is good for you in many, many ways. This is an article that talks about 8 different ways that garlic can be helpful. I don't know how many of you use garlic, but it is likely to improve cardiovascular health, resist osteoporosis, which is a problem of older people, and it has anti-inflammatory and GI things. As you can see, they list the 8 things: antiviral effects, reduce blood pressure, improve your GI metabolism, and have anti-cancer properties. And many feel it contributes to longevity. The anti-inflammatory benefits are pretty well known, and the bone health aspects are good. And the last one they talk about is the improving cognitive functions, preventing the decline of cognitive memory, especially with Alzheimer's. And these are they talk about the way to use garlic. I don't know how many of you use garlic, but I think I've rarely used garlic, and some people talk about bad breath that occurs as a consequence. And if you're on blood thinners already, then garlic is a problem, because it causes blood thinning medication to be more effective.
Well, I'm a believer in garlic, and the solution is just whoever you're with, have them eat garlic too, and nobody complains about bad breath.
Okay, that's one solution. How many of you out there eat garlic?
Me.
I put garlic in almost everything that I cook. You know, a lot of the Asian dishes is garlic and ginger. So
Mhm.
it's a staple in foods.
Then go upstairs.
Yes, I use garlic for everything.
Okay, well, good.
But
And
the
ginger is great for digestion.
Yes, ginger is great for a lot of things. The one thing about garlic is that you have to watch garlic when you buy it, because they have it on the shelf, and if the bottom of it is molded or black, don't buy it. It's toxic. So you have to watch garlic very carefully when you purchase it.
Okay. This is an article that talks about stop drinking, keep reading, and look after your hearing. As this neurologist, those are his tips for fighting Alzheimer's disease. Of course, we are increasingly looking at this because we do not have any way of effectively treating Alzheimer's or dementia for that matter. And so the emphasis is therefore on doing those things that seem to be associated with good cognitive function. And so there's an emphasis by many on doing the cognitive things that are helpful, as we talked about before. We talked about the chess and checkers and reading, and of course, not drinking a lot of alcohol, because there does seem to be an impact to that. And then, of course, there's an article that says cannabis is part of a cause of cognitive dysfunction as well. It's interesting how reading is thought of as a great way of doing this, as is meditation, by the way. It's a good way of challenging your brain. It's interesting that as we age, our memory does decrease, and so these gimmicks may help us retain our cognitive functions well into our 60s, 70s, and 80s and 90s. So it's interesting that they make this comment, although I'm not sure that it can be proved by limiting the risk factors we talked about before. And alcohol is one of them. And cannabis is now thought to be another one. So it's a word to the wise to do those things that test your mind, and avoid those things that we know detracts from your mind. And so being active, being social, all of those things are positive things that could be helpful. And debating is probably helpful as well. And of course, one of the most painful things is to see somebody whose mind is just decaying in front of you, and who no longer is able to recognize you or remember anything. So an ounce of prevention, once again, is worth a pound of cure. That's an article that is long overdue in terms of having telepsychiatry, so that we do away with some of that stigma that is associated with mental illness because of coronavirus. The use of telehealth increased dramatically, and this also results in an increase in telehealth visit to the psychiatrist, which is great, because I think the more ways we have of interacting people with mental health professionals, the better off we are. It's interesting that the telehealth services are more likely in urban centers when they're needed more in rural centers, but that's the way life is. And so the more ways we can get people to address their mental health concerns, the better off we are. The biggest issue from my perspective is payment. And then, of course, the other problem is with telehealth, you may have difficulty reading the patient's nonverbal cues because these are as important as the verbal cues. And then how do you establish rapport with the patient by telehealth? Those are areas that we need to work on to improve our abilities. But I think that this is an area that is underutilized, especially for mental health issues. Of course, a lot of it is based upon the reimbursement practices, which need to be updated. I think it's good that the president has emphasized the need for more coverage for psychiatric issues.
Dr. Callender, I had a question about the difference between psychologists and psychiatrists. And I thought the big difference was that psychiatrists can prescribe medication and psychologists don't. So do you have
psychologists can prescribe medications, but more often, the difference is the psychiatrist is an MD.
Right.
Okay. Psychologist is he's got a doctorate, could be in education. For example, Robinson has his doctorate in education. It could be in psychology, it could be in anything else. So, but there are psychologists who can prescribe medications. But all of the psychiatrists can prescribe medications. To me, the difference is that the psychologist is more likely to be willing to spend time with you and not to medicate you. And because Dr. Robinson emphasized to us many times that there's a special niche and special role that interacting with the patient and psychological interaction plays that medication cannot play. And the problem is that they don't pay that well for spending time with the psychiatrist. Whereas if you see a patient and give them medication, you don't have to spend that much time. And so reimbursement is based upon time. And so time is money. And so many of these psychiatrists will spend much more time with medication than psychological interaction. And so that's one of the ways, that's the difference in some ways between psychologists and psychiatrists. There are psychiatrists who emphasize psychological interactions, but more of the psychologists would recommend that than psychiatrists. More psychiatrists will rely on medications, and in some ways that represents one way of looking at the difference. But whoever you want to see, a psychologist or a psychiatrist, they are mental health professionals.
Dr. Callender, what about this edict that the psychiatrists, they prescribe medicine, but in telepsychiatry, should they really prescribe medicine to people that they have not physically seen?
You can, yes, you can. Telehealth is a way of doing it. Yes, you can prescribe medicine for patients who you interact with over the telephone or over video. The interaction is what matters. The best interaction is a patient encounter, but if you have interaction that involves telehealth, you can prescribe as well, because you've had the interaction. It may not be the optimal interaction, but it's an interaction nonetheless. And you've established a doctor-patient relationship.
There are doctors that won't even prescribe anything unless they see you.
Yeah, that's a reasonable practice. but we're getting to the point, especially in rural areas where you may not have access, that exceptions to that rule. This is an article about naps, and we've discussed this as well, but this is one that goes into great extent about the advantage of naps. And they think for most people there's a benefit to napping. And then there's a degree of napping that you do that matters. One of the best benefits is if you're not getting enough sleep. So if you're not getting 7 to 8 hours of sleep a night, then you need to do that. So taking a nap might be helpful, because that can help support the healing process, because you need to get rest. And the advice is 7 to 8 hours a night. Now, saying this, they point out that there's some health risks associated with naps. One study showed that people who nap during the day are more likely to have high blood pressure, and more likely to have a stroke. Of course, that depends who you're studying and the age of the patient. These are observations that have been made without really identifying what group of patients you're talking to. That's why knowing what's the ethnicity and the age of the people you're talking about becomes critical before you make determinations like that. The question about certain people should avoid napping. Well, I think if you are not sleeping enough, maybe napping might be good for you. But if you have insomnia, it's thought that that's not going to help you much, because what you need to do is sleep at night and not sleep during the daytime. It depends on many factors. Is there such thing as too long a nap? That varies. Again, this article doesn't really help you much, because it depends why you're taking the nap. That's what matters. If you're taking it because you didn't sleep last night, or you were too busy and then only slept 4 hours and you need to catch up, it's probably a good thing. But just to take a nap is not necessarily a wonderful thing, unless you take it for 15 to 30 minutes or less than an hour, in which case there's evidence that napping for less than an hour is therapeutic.
Mm-hmm. Dr. Callender, some people take naps to avoid life. They're depressed. What's your take on that?
Well, that's a good example of when napping is not good, because doing that's not, you need professional help. That's what you need, not nap. You need professional help, because that may be a sign of depression. Now, there's a number of articles recently about sleep, and one of them suggested that the reason that African Americans aren't as healthy as they could be is that when they're younger, they don't sleep the 9 to 9 hours a night that they need in their children. And so that it's important for kids to get that 9 hours of sleep at night. Then talk about the sleeping positions and which is good for you and which isn't good for you. And this article goes into great detail to identify the many different positions that you sleep in and what's good, what isn't good, and the long and short of it is that the way in which you sleep depends upon many factors, and when push comes to shove, the fetal position, the brain plasticity theory is something we've talked about before. It's important to look at this and to recognize that sleep is a way that your brain reshuffles memories and flushes out toxins. This is the brain plasticity theory. And this is important to understand because that's why sleep is so important. Now the question is, how do you sleep? Do you sleep? What's the right position? And this article looks at all of the positions and concludes that many of them are desirable. But I think that personally, I think that the position that they come up with is the best, is probably one of the worst, is that sleeping on your back, if you have eaten or something, aspiration is a complication that can occur. Where sleeping on your side is probably healthier because you're not likely to aspirate. And aspiration is one of the complications. So that, and it's been interesting to see what position you found that works for you, because everybody is different. And you see here, they say back is number one, but I don't agree. I think the position that you sleep best on is the position you should sleep on. Although the fetal position is one of the better positions because it also helps you breathe better because snoring is more common when you sleep on your back. But
Dr. Callender, I have a question. You know, with infants, I guess the thing is to have children sleep on their backs. Is this training them to be a lifelong back sleeper?
I think one of the reasons that happened was because the sudden death syndrome was thought to be related to the way you sleep, and they thought that sleeping on the back prevented the sudden death infant syndrome. I thought that was the reason why they did that, not to.
Well, I understand that. I'm just saying, inadvertently, are we training people to be lifelong back sleepers?
I don't know that the way they sleep when they're infants is the way they're going to sleep for the rest of their lives, because there's so many other factors that change from being an infant to being an adult. How many of you sleep on your back?
I sleep on my back, my side, anyway I'm comfortable.
Yeah, okay, and that's how most people do it. They sleep on the side that's comfortable. But it is clear that if you eat before you go to sleep, that sleeping on your side is probably healthier because you're less likely to aspirate. But
maybe you could address the physiology of it. If you've got something in your stomach, it's better to sleep on your left side, I've found, than your right side. Sleeping on your right side with there's stuff in your stomach will promote, I find it promotes indigestion.
well, I think it depends on many factors because when you look at it, your GI tract leads to the duodenum, which promotes food going down on the right side. On the left side, as long as you're, I think to me the right side would be more advantage than the left side. Although left side sleeping position has its advantages as well. I think the side position is better in terms of preventing you from aspirating. This article recommends the left side rather than the right side. I'm not sure the indigestion, and I think what this brings up is heartburn, because when we talk about indigestion, we're talking about heartburn, which means that your esophagus, food goes from your esophagus to the stomach. And if you have reflux, the food that goes back up into the tube, and that causes reflux, and that's what indigestion is mostly about. And sleeping on the left side is recommended for that reason. But it requires that you have a dysfunction between the stomach and the esophagus, which is a common complaint. And so that's why they have this on as the clear winner, is that they think that sleeping on the left is a remarkable list of benefits for your health and well-being. But I'm not sure that I quite agree with.
Well, just I did a Google search, and it looks like Google says that for digestion, sleeping on the left side is better. Their reasoning is that there's no medical evidence to support sleeping on one side is better than the other. However, the location of the stomach is a clue. The stomach's natural position is on the left side, where it can digest food more effectively, and that gravity can help take waste on a trip through the ascending colon, which into the transverse colon can finally dump into the descending colon. And that's,
Well,
they say that that's facilitated by sleeping on the left side.
Yeah, the only problem with that thinking is that the colon is a long way off. Once you go from the stomach, you go to the small intestine, and you go first to the duodenum, which is actually on the right side. And so dumping into the small intestine is what I would think is better for you. But it's clear that there's a lot of debate about it, and that the authors seem to agree to the left side. I just, knowing the way that food goes down, knowing that the duodenum is on the right side, and the colon is a long way from the small intestine, so that's why I have a little disagreement. As you said, there's no study that proves it one way or the other, but most people agree with you that's on the left side. I don't, though. Knowing how the stomach, however, if you have a full stomach, then and the stomach the food does not get into the intestine, then the likelihood of backup is there. So that may be why many of them agree with the left side rather than the right side. Having put down a lot of stomach tubes and dealt with people who have intestinal obstruction, I've developed a sense that having the food on the right side to encourage it to go into the intestine is wise. But I defer to your Google search and and this study itself that says the left side, although my recommendation is the right side.
Dr. Callender, I sleep halfway on my left side and halfway on my stomach.
Well, I think the best way to sleep is what makes you comfortable, and if sleeping on your stomach makes you comfortable, go to it, because I think the bottom line is you need to get sleep. And
what makes me comfortable is, I think it has a lot to do with the brain functioning, because I use a pillow when I sleep, and so the pillow has to be positioned in the right place for my head. So it seems as though my emphasis on sleeping has to do with my head being in the right position on my pillow. So it ends up being half on my stomach and half on my left side.
okay, well, whatever allows you to get the most sleep and the most restful sleep is what I'd recommend.
Yeah, Dr. Callender. Hello.
Yeah.
Yeah, myself, I don't have a particular way or side of sleeping. When I lie down, first of all, at the first time on my left side, after about an hour or so, when that side of my body starts to pain me, then I will switch to my right side. And when that side starts to pain me, I will just lie on my back and so forth until I fall asleep. How does that correlate with, because I don't really know which side that I eventually fall asleep on.
Well, I think common sense is important. And so therefore, whatever works for you is what you should do. You know, right now, the data does not say absolutely you must do this or that. And so
Yes.
therefore, you must listen to your own body as it speaks to you.
Yes, okay. Thank you.
Now, what is long-term cannabis use doing to our brains? And this is a study that looked at cognitive deficits that occur as a consequence of alcohol and mostly marijuana, which is thought to be harmless. And so this study, of course, we again have to recognize, as Mark and Darryl had pointed out, who are they studying? Are they studying people of different ethnicities or of one ethnicity over another? Talking about, well, in this study, they studied people who are middle-aged or over, and some would call them seniors, but anyway, they talked about cannabis use among those who are 65 years and older, and and it appears that in the New Zealand group that they studied, they followed until age 45. 94% of the participants completed the study. Remember, it's New Zealand. Not too many of us over in New Zealand. And so they found that they were IQ declines at midlife. They started studies at younger ages, but they found that by midlife, the cannabis users had lower IQs. And there was interesting comparison between tobacco and alcohol use in terms of the long-term negative impact on IQ. And so this then got them to recognize that cannabis is not harmless and that cognitive dysfunction was common among the alcohol users and the cannabis users, and long-term nicotine users. So that it's suggested that you need to recognize that cannabis, using long-term cannabis use is not without its complications, just as long-term smoking and long-term alcohol use has its disadvantages. Any comment on this?
So Dr. Callender, what are they saying in terms of the cannabis for medical use? I mean, I thought this was a big thing now that they were promoting cannabis for medical reasons.
Well, I don't know a big thing, but there are some people who are quoting it for different medical uses. You're right. Originally, they used it for glaucoma, and then they used it for pain, and so there are medical uses. But the point they're making is long-term cannabis use has its side effects. So that's the moral of the story. Whatever reason you use cannabis for, long-term use of it does have its negative impact, just like side effects for all medications, except maybe water and air. But this then, cannabis has its side effect as well.
Dr. Callender, they're saying the same thing about vaping.
Yes, they're saying this. Well, they haven't done studies long enough on vaping, but yes, they are saying the same thing about vaping. Yeah, except the pulmonary complications of vaping are more severe. This is an article. Yeah, go ahead.
It's confusing because they're saying that people vape in order to quit smoking because smoking is worse than vaping. But what is the point if, cigarette smoking is going to take 20 to 25 years off your life, and vaping is going to take 15 to 20 years off your life? Both are bad.
Well, I guess you said it. Yeah. Mhm. I guess you choose your poisons. Yeah. This is some good news. We talked about this last week as well, that over-the-counter hearing aids are going to be available at a cheaper price, which is good in many ways, although 30 million adults could benefit from hearing aids. And most of them don't get their hearing tested, and they don't listen to the family members who tell them that they need hearing aids. So maybe some of them will get them. Now, the question is, if they don't get hearing tests, how will they know how to use it optimally? And of course, that is not as much of a factor as the fact that most of the people who have hearing deficiencies don't use hearing aids at all. And so I think that's why they decided to do this, because if we could just get half of the people who need hearing aids to wear them, then that's better than it is now. That's what I think is the reason why they decided to do this.
Yeah. Is loss of hearing, is loss of hearing becoming more prevalent? I'm saying that because I see a lot more advertising. I receive stuff in the mail. If you go to the drugstore, hearing tests, and now they're making it available to get it from drugstores. You don't have to go to your doctor. Is it common for seniors or just?
No, 50% of people over 70 can't hear. So it's very common. It's just that we ignore it, but it's very common. And I don't know whether it's getting more or less because the people who can't hear don't go to get audiology testing, so they don't accept the fact that the people they love can't hear them. That they say, I can't hear you, I can't hear you, I can't hear you. So it's common. It's just that now, as we age, the data says that 50% of people over 70 have hearing deficit.
Yeah, Dr. Callender, I mentioned this before. I've had severe hearing loss over my musical career, playing on stage with loud speakers and loud drummers right next to me. And my hearing, my audiology profile shows that my high frequencies are lower, especially in my left ear, because I was right next to one of the world's best drummers for like 10 years. Anyway, people who don't have those kind of audiology studies or tests are just getting like a boost in the overall sound, which could be even more damaging in some respects. Everything is louder, not just the frequencies that they may be lacking. You hear what I'm saying? Because you go, it's like the people who buy. I think Janet said this before. Who buy the glasses at the CVS? You try glasses on. Oh, this is good, but it may not be exactly to your prescription.
Well, that's true, but it all depends upon whether you recognize that more people will now be hearing better than they ever had in a while. And so I think you accept some of the downside because it's a much larger upside.
John, maybe I can address some of that. And okay, like over-the-counter hearing aids or do-it-yourself things. Like for a while, I was doing Apple AirPods as a do-it-yourself solution. And one of the things that left on my own, yeah, I amplified all of my audio, and so it was louder, to compensate. But when I went to a hearing aid specialist and got hearing aids, and it fit my prescription for my hearing loss, instead of amplifying everything sounded very natural as far as volume level, but it was just clearer. And so, I could make out conversation, but I wasn't boosting the volume. And so, what happens is people on a do it yourself basis, if it's not programmed by a professional, they do tend to make it louder and to the point of giving themselves more hearing damage. And so, you got to be careful with that. So, maybe the over the counter things are a better solution than not being able to hear at all. But what I've found that it's very helpful to have a professional guide you into your hearing recovery. And just on a side note, for a musician, a couple of weeks ago I was playing on a very loud festival stage, and it was so loud that after the gig was over, the other musicians on stage, everybody's ears were ringing. It was so loud they couldn't even make out the music that they were hearing on stage. But that was a night, for whatever reason, I forget why, I didn't wear my hearing aids. I wear my Apple AirPods, and it's got a sound isolating feature. And so I turned that on, and it dropped the music level by maybe about 25 dBs. And so that the volume was low, but I was able to hear everything perfectly without getting my ears blasted out.
Very fascinating discussion. Good. Well said.
I use in-ear monitors on the stage, which have really protected my ears as well. I have control over the overall volume, not the frequencies like you were saying, but the overall volume. And when I turn it off, it's like I've got my fingers stuck in my ears. I can block out everything. It's very, very helpful.
Okay, well, we will see what's going to happen. It's interesting. This is a very long article that talks about how the biases of physicians wound up affecting generations of Blacks who had ankylosing spondylitis, and they tried to blame it on so many different things. But the bottom line was that they had a disease that the physicians thought was not common among Blacks, but exists among Blacks. And so the medical bias, as a matter of fact, I had a classmate, a guy I finished high school with, who died from this kind of condition. And this is the bias of physicians will cause a problem. Ankylosing spondylitis, they said, doesn't happen in Black people. Well, of course it did. It happens in people. It's less likely to be present in people. And so because of their dismissiveness, which occurs when people do not understand what is going on, this particular person did not have her disease treated. And so the bias of physicians is something that has been problematical forever, and it's less so. There was a time when they said Blacks don't feel pain like white people. And so this then is another example of something that is thought to be rare in Black people and is dismissed. When you go back and look at it, you find out that that's not the case. And this is this person who had ankylosing spondylitis who had this kind of, and as a matter of fact, when they looked at the skeletons, they found that Black people had it as well as white people, but they just ignored it and denied it. And
I know someone who was going through that and was recently diagnosed with it. She goes for monthly infusions or something now, but she's doing much better, much better.
yeah, and without treatment, it's just painful disease that
Mm-hmm.
is not no remedy other than some of the immunosuppressive drugs that they now treat it with. And so the moral of the story is that you can't rule something out that just because it's commoner in one ethnic group than another. And this, they bring out many other things, the Tulsa Massacre, which is a tragedy just like the one in Florida. And so, and this is, of course, one of the disgraces, many disgraces that we have in this country. But I think that's the moral of this long article, that the biases of the physicians wound up in hurting our ethnic group because they said it didn't occur in Black women. Of course it does. So that's the moral of the story. And so when you go to the doctor, it's important that we minimize the biases of the healthcare professionals. They all have them. We all have them. And so we have to try to do what we can to make sure that they treat us well. Just as with COVID, even though, although we talk more about COVID, the group that is affected more adversely than Blacks by COVID is the Latino Hispanic population, which has worse prognosis than African Americans. But they both don't do well with COVID. Anyway, that's the long and short of this very long article. This is an excellent article that talks about prison to college pipeline, and it's role modeled by Chandler Idris, who was in prison and now is an endocrinologist, scientist, and professor who has a PhD and an MBA. And he is now put together a pipeline. It talks about how he had a mentor that allowed him to study while he was in jail. And then this resulted in him becoming an outstanding PhD and him now developing a pipeline that allows incarcerated people to be educated and get to college. And this is something that is relatively new and very desirable, since most of the people in prison are African American or Latino Hispanics. So this affects us more than anybody else. And so it's just wonderful to see this legacy as HBAC as a tool for Black liberation. So I think very proud of what he's accomplished and what Howard is recognized as a consequence of his using his platform. This is important because more than 50% of those people who leave jail go back to jail. So it's important to have platforms like this, just like prison ministries, same thing. Any comment on this?
Do you know him, Dr.
Yes.
Callender?
Yes, yes. Yeah, we're on the admission committee together.
Wow. How old is he?
He looks like he's in his about mid-40s or 50s
Oh, okay.
now. He was 21 when he was in prison.
It's great.
It's awesome.
Yeah,
I
it's
think that's a
awesome.
wonderful story.
It
Yeah.
is
You know, I
second
wish,
chances, second chances. Yeah.
yeah,
Mhm.
you know, maybe they could recruit some inmates to also be lawyers, because there's only 3 states that ban felons from practicing law. That's Kansas, Mississippi, and Texas. But, you know, it'd be great to recruit felons to, you know, to any professional level.
Okay, I think that's one of the nicest contributions that Howard has made. He's made many, but that's an outstanding one. This is an interesting article because it talks about a special category of healthcare workers who were fired over vaccine mandate, because the mandate does not say that you have to get a vaccine if you have religious reasons. And there are some employers who refuse to grant religious exemptions. And so this only applies to those places where they had religious objections and they were fired anyway. So all of those people will be eligible for compensation. But this does not apply to those people who didn't have religious objections. So this is an interesting feedback and they single out Illinois healthcare workers. Same thing, this is same thing that talks about the Supreme Court finding that if you have a religious objection, that we can't force you to take the vaccine. Many people didn't have religious objection, they just didn't want to take the vaccine, but that's different. But if you have a religious exemption, then you can keep your job. This is an article that is just like previous articles with Tony Fauci and President Biden, and now his first lady retested positive after taking medication again. It's the same thing that happened with the others, Paxlovid.
And she's positive again.
Right.
Yeah.
Just like the others. Yeah. Just like Fauci and
Right.
her husband. Right. Yeah. So the rebound positivity is it's just like I'm supposed to go to school tomorrow, and they are not interested in your booster. They want you to have a negative COVID test the day before coming.
Mm.
Because they recognize this rebound phenomenon. So,
Dr. Callender, I didn't hear about rebounds really until Paxlovid. Any relationship between those?
yes, it is. Yeah, it is related to it. It's a complication that occurs in 10% of the cases, they say. But of course, this is a new drug, so we don't know a whole lot about the rebound phenomenon, but we'll learn more as we see. Initially, it was said to be 10%. Whether that's still the case or not, time will tell. Well, this is an interesting article about the plan for the end of COVID-19, which it's not ending soon enough. But eventually the plan is to shift the reimbursement from the government to insurance, which is the way most vaccinations are handled. And this is a reasonable expectation. However, it's clear that that's not what is expected to happen this fall. But it's down the road, it is expected to happen. It's amazing, though, how much these Pfizer is made off of these drugs. So anyway, this is something that is real for us, and I think the most important thing is that everybody gets their boosters, and that in the fall, when the new vaccine is available, that everybody over 12 is expected to be eligible and is expected to take the boosters. These new boosters will be particularly targeting the new BA.4 and 0.5 strains of the virus. Whether you should get another booster or not, in the meantime, is a point for a lot of discussion. The bottom line is, if you are immunocompromised, the sooner you get your booster, the better. If you're not immunocompromised and you already gotten a booster, and the question is whether you want to get it now or you want to wait until mid-September. It all depends on, if you're in a high risk category, I'm not in favor of that, because you could get the virus and be sick before you get the new booster. So,
Dr. Callender, I have a question. For the adults that have had the 2 boosters, are we scheduled, or are we scheduled for a 3rd booster, or?
yes, you're expected to get a 3rd booster when it becomes available. The time for the boosters is after 4 to 6 months. And so, yes, the expectation is that in the fall, which is next month, that you would be expected to get an updated booster shot.
Oh, wow. Okay.
Yes.
Dr. Callender, I heard that, well, someone recommended to wait till October but be prepared for the.
I think that's bad advice. And if your booster is out of whack, see, you got 4 to 6 months between booster shots. So if you're more than 6 months beyond that, then you need to get a booster now. But if you're not more than 4 to 6 beyond that, then you can wait for it because you're already boosted. But that depends whether you're high risk or not. Very high risk, immunosuppressed. I would recommend that you get it. But again, it depends whether you're 6 months beyond your booster shot or not. If you're within 4 to 6 months, this is equivocal. If you're more than 4 to 6 months, then you probably should get the booster when
So
you can.
Dr. Callender, do you get that the same time as the flu shot? Let's say
we discussed that last week as well. That's optional. You can get it at the same time, or you can get it at a different time. It all depends on what your mindset is about it.
Mm-hmm.
It's optional. This is Fauci's warning. Vaccines and boosters now, you're going to get into trouble, because he expects this fall to be a difficult time for COVID. And those people who are not vaccinated, almost 5 times higher than those who have been vaccinated. At least the hospitalizations are.
Dr. Callender, do you keep getting boosters? Is that something that you get every 4 months, or at some point, is it just an annual shot like your flu shot?
Eventually, I believe it'll be an annual shot. Right now, it's every 4 to 6 months. As we learn more about what's happening in the previous 4 to 6 months, we will know better. Right now, it seems as though every 4 to 6 months you need to get a booster. Now we'll know more as we, because now it's about a year, more than a year for those who initially got the first shots. And so we will know more, be able to answer better. Right now, it is a recommendation every 4 to 6 months. And then depending upon what happens after we do this next booster shot, we'll have to see whether we do it in 6 months or whether we wait a year. So we don't know yet. I guess that's the best answer.
All right, thank you.
It's interesting we have so much violence in this country. Here a lot of the violence is related to gender changing and other things. So that and the problem is misinformation and disinformation getting out, and then people acting on mis and disinformation, and they're violent threats towards people. And there's one, well, there's an article that talks about one of the people who actually committed suicide because of the mis and disinformation. But a lot of it is related to LGBTQs and gender surgeries, so forth, and misinformation. Boston was the first pediatric and adolescent transgender health program in the United States, and there are a lot of people who feel that doing transgender operations on children is inappropriate. But people like to force their opinions on everybody else. So some of the violence is related to that. This is a unique area because so far there aren't a large number of children who are requesting that kind of surgery. And so the parents of these children have to make a decision for them because they're minors. What is clear is that violence in this country is just accelerated beyond any expectation. You see the violence on the subways now, and never had before. Different kind of violence, stabbings and shootings. That is sad. And it's interesting that they're trying to classify LGBTQ people as pedophiles, which has never been documented. But anyway, this is how the social media has been abused and misused. Any comment about those articles?
Can we blame them for the monkeypox?
Blame who for monkeypox?
The LGBTQ plus.
No. Males who have sex with males. That's only males who have sex with males. That's the only category that is thought to be associated with monkeypox. So far, 98% of the cases are in males who have sex with males. Okay, any other discussion points?
I think we have some new people join us today. Do we recognize them?
Okay, then why don't we, let's see him. Can you get off the screen and let's see everybody who's here?
The iPad 4. Who is it?
Well, no, why don't you get off so we can see all the people who are here? So if you stop sharing your screen.
I did.
Yes, yeah.
Well,
I
there
stopped
are
My name
15
is
people,
Vivian.
we can't see them.
That's
Oh,
Perlene.
The iPad is Pearline. Okay.
Yeah, iPad is Perlene.
Oh,
What about the
Also,
Galaxy?
I'm new. My name is Vivian Blake.
oh, hello, Vivian.
How
Welcome.
are
This is your
you?
first time?
No, I was on the last one also.
Yeah, that's right. Yeah, okay. Anybody else? Aretha Williams. Are you new?